Yeah, I think we're ready to get started. Florian?
Yes.
Hi. Okay, just do a quick introduction. So, afternoon, everyone, and welcome to the EFPC webinar series for 2024. For those of you who are not familiar with the European Forum for Primary Care, in a nutshell, we bring all stakeholders together. Sorry, I was just trying to mute someone there. We bring all stakeholders together within primary care, academics, policymakers, practitioners, patients, and informal carers to discuss the organization of primary care and how to achieve the best output, the best results, and the best healthcare for the populations there needed in Europe. So today we will be having a talk on advantages and challenges of AI in primary care medicine. Our speaker today is Dr. Florian Stummer. He is a leading authority on telemedicine and healthcare innovation and is directing telemedicine research at the Medical University of Vienna's Department of Primary Care Medicine. With a broad academic background in multiple fields, Dr. Stummer is actively engaged in teaching and has made significant impact on the integration of artificial intelligence into primary healthcare through his research and publications. So without further ado, I'd like to hand over to Florian to take the floor and lead us on a insightful and innovative talk for today. So just quickly, if you have any questions, please put them in the chat throughout the presentation, and we will address them once Florian has finished his presentation.
Thank you so much, Robin. I'm hopping over to the presentation now. So, can everyone see this?
Yeah, it's still,
yeah.
Just need to start from beginning and then we'll have, because we can see your notes.
You can see my notes. Okay, that's no good. Let me check. How is it now?
No.
Still the one with the notes?
Oh no, I can't see anything now.
Okay.
So it was sharing well, it was just you needed to start the presentation.
How's this?
Nothing yet.
Sorry, but what can you see now? I have two windows open now.
No, so we can't see anything. It's just yeah, that's perfect. Yeah,
there it is.
100%.
Okay, thanks so much. Thanks so much. Yeah. Have a lovely afternoon now. As always, the initial troubles, but you are lucky. Last time everyone had a broad smile on their faces, and I thought it was because of my witty presentation, but it turned out that one of the filters of my daughter was still on, and I had fluffy orange dog ears. So I'm very grateful that it is just this time. So, well, let's start. Our advantages and challenges of AI in primary care medicine. Now, we will cover in this webinar three major things. I try to boil it down as good as possible. On the one hand, that we get an understanding of the potential benefits of AI in primary care medicine, pivoting around diagnostic accuracy, create personalized treatment plans, improve patient monitoring, very easy and basic stuff that everyone can reproduce on yourselves. And we will discuss the challenges and limitations, which primarily are grounded in data privacy, security concerns, of course, biases in the AI algorithms, then the need for proper training and adoption among healthcare professionals and providers to use it, and we explore a real-world use case which you can try on yourselves as well at home. For this, we will provide a short PDF afterwards that can be sent out to everyone to make tests. So, the definition of AI. Artificial intelligence refers to the simulation of human intelligence in machines programmed to think, learn, and problem solve like humans. For healthcare, this means that AI encompasses various technologies that allow computers to analyze complex medical data, providing insights and facilitating decision-making processes. Now, what seems very clear and very simple, as with all the things that look simple, becomes very complicated when you dive deeper into the topic. There is a funny story, a funny anecdote about how the term artificial intelligence was coined for the first time. It was like this, that Professor Norbert Wiener, who was in the US a big number and one of the heads of the forethinkers around cybernetics in the 40s and 50s of the 20th century, had this because he knew so much, he turned up at every congress that had cybernetic in its title. And when the speeches and the presentation started and in the pauses, primarily he was talking and no one else. So in the year 1956, Marvin Minsky and John McCarthy thought about, now, how can we have a conference without Norbert, without showing him up and telling us how cybernetic works, because we're actually doing something completely different. And then John McCarthy came up with the idea, let's call it artificial intelligence. When Norbert sees artificial intelligence, he won't show up. And that's exactly what happened. So only the people around the development of artificial intelligence met at Dartmouth College, Dartmouth University for the summer research project. And this was the very first time that artificial intelligence as a term was used and coined and branded. Now, there is a trinity of AI and AI usage right now that on the one hand works and is in use and is developed, and on the other hand is relevant for our usage and needs in primary care medicine. On the one hand, there is the first pillar, the machine learning. Machine learning defined as AI that enables systems to learn from data and improve the performance over time, but without being explicitly programmed. So it's doing stuff on its own. Potential application in healthcare would be like machine learning algorithms that can process medical data, live medical data streams, identify patterns live, and of course predict outcomes, predict or derive solutions by identifying patterns, which can be, as an example, seen, for instance, analyzing patient histories, predict disease progression or response to treatments, not only for individuals or for certain diagnosis cohorts, but also for populations, like in epidemic situations. This is where machine learning comes in and does a pretty good job. Now, for the second, what we as practitioners can use now are natural language processing models. Now, these NLP or large language model processing models primarily focus on the interaction between computer and human language. So to make things easier, machines learn to understand, interpret, and respond to text and spoken words by human beings, which makes them more applicable, more feasible in using them, and of course more easier to use in certain questions and certain issues, than going through long data columns or diving into old reports, patient reports to find something. Now, there is high potential in using it. These natural language processing models extract meaningful information from unstructured clinical notes, for instance. We all know how much data goes with one patient from the moment he enters the hospital until he leaves. Many notes are taken, many short memos and short lines are drawn somewhere or written down somewhere, either from physicians or from nurses or dietitians or physiotherapists, whoever the patient passes on his way, on his treatment way within the system. Now, using such models can enable better data utilization for the patient, but also help with, for instance, optimizing transcripts or clinical documentation. And finally, predictive analytics. Predictive analytics as AI in an AI corpus primarily takes statistical techniques, machine learning algorithms, and try to find out vital stuff, crucial information from historical data and make predictions to the future. Now, may it be identifying at-risk populations, may it be to improve resource allocation, predicting a patient, the development of complications with multimorbid patients, improve care management. Now, all of this is predictive analytics based on data, on historical data, and also comes and runs with AI. Now, for the benefits, just to make it once more clear, what is it doing as such? These natural language processing models or large language models take data, raw as it is, text, images, speech, structured data, of course, as well, and 3D signals, and so forth. This data, these primary databases, are fed into this foundation model, as they call it, respectively the large language model itself, and then can be adapted to certain tasks. It can be asked then questions, sentiment analysis, information extraction, image captioning. So many things just by taking and looking and understanding the primary data in the database, and then asking it, can you help me with X, Y, Z? And then we get an answer. The benefits of it, on the one hand, is reducing manual labor and the costs, enhancing availability, personalization, and satisfactions. We are talking about, for instance, information bots, healthcare bots, where patients can ask questions themselves. The machine dives into the existing or the knowledge base we provided, and then it gets out the necessary information. It increases accuracy in tasks. There are always minor problems or major issues or misunderstandings. Now, this is something such models can get rid of. The challenges, however, are in the field of reliability and bias. Of course, the answers can only be as good as the quality of the primary data that went in. So the more corrupt and the more biased the initial data is, the more problematic are the answers and the interpretation of the answers. Another challenge is the context window. Until now, we are only talking about a certain amount of words or information that we can feed into such large language models. Let's take ChatGPT, which we'll use in a second for a little experiment. You can only feed it a certain amount of words, 1,500, 2,000, whatsoever. Now, this means it only can frame its knowledge with our request in these 1,500, 2,000 whatsoever tokens, but cannot see the whole picture. So we humans get the problem that with their prompting, meaning how you ask the machine and what are you asking it, will stick in a certain frame of knowledge and of the topic and of the issue that you want to ask and be worked on. System costs. Running such systems is highly expensive. and the environmental impact becomes more and more problematic. For instance, there is a certain program, BioBird. BioBird is an biomedical large language model that is trained by a corpus of 4.5 billion words from PubMed papers, 13.5 billion words PMC. And all of this is put together, pre-trained, and then can be asked and fine-tuned for specific tasks, like named entity recognition, because as it can check pictures and images as well, you get certain answers around pictures, graphs, and other visualizations, or for relating extractions like CAM protocols. Asking it, are there variants in the genes region contributing disease susceptibility? And it comes up, dives into the material, comes back, yeah, it is. Or question answering games like BioSQ. What does mTOR stands for? And then it gives you a clear explanation, like in a search machine. Now, training this model, for instance, needs as much energy as one flight trans-America. Now you can imagine when it is just done for one issue, and if it is trained for broader stuff. So this means a high environmental impact. The benefits, of course, when you have such clinical language models are it becomes easier for medical transcription. Searching in electronic health records becomes more profound and more elaborate. Clinical decision support becomes more stable. Medical research assistance can be provided through a broad and very vast usage of research results and papers and findings, which become more and more each day. You can generate automated patient communication for certain illnesses, diseases, or situations. Predictive health outcomes, personalized treatment plans, medical coding, training and education, ethical and compliance monitoring. Now, all of this becomes very specific and very deterministic when you use it in a set of clearly defined boundaries and limitations in clinical or medical language model, which is a subset of large language models. The challenges, however, are accuracy and reliability again, then the generalization versus specialization, because these machines, these models can only be trained on general information. And finally, biases and ethical issues, which again come with the quality of the primary data knowledge base we feed it. Okay, so now for a test, I show you an example of an customized GPT done by AI Research plus LinkedIn and X. I'm not sure if this, it is not very clear who did what, but the idea of this customized GPT bot is it's a smart healthcare resource for health and medicine research, health and medicine education, medicine and medical resources, but no tailored medical advice. So I will hop over now to ChatGPT. I prepared this presentation already, so we can work. Do you see this now, the tree of thought model?
Yes.
Yes.
Okay, thank you. And we start by understanding how we are talking. We all know how an anamnesis works, and it somehow is exactly like this. It's like that we are talking to an expert or some kind of expert entity with a certain knowledge base, and we can ask it and interact with it in certain ways. Prompting as such means just what do I answer, what do I ask, how do I interact with the model so it understands what I want. There is one way, the input-output formulation, which is just like, can you tell me X, Y, Z, and it comes back with an answer. Or is it true that, and it comes back with yes, no, and an explanation. A more decent form of using it is the chain of thought prompting, which means you ask a question and additionally ask it, please show me the steps. how you come to this out to the conclusion. Which reasoning do you follow to come up with the conclusion? A subset of this chain of thought prompting is the self-consistency approach, where three different ways, three different databases are used to come up with one unique answer that we are looking for. And the newest way to talk to the machines is the tree of thought method. Now, this tree of thought method is insofar interesting when it comes to interdisciplinary and multidisciplinary work, which we are facing in primary care medicine. Now, with this prompting technique, what we are actually doing is we ask the machine to pretend to be three different experts. Like you are expert 1, you're a general practitioner, expert 2, you're a nurse, expert 3, you're a physiotherapist. And then we ask it, with this approach, we ask it, please take the database and your knowledge base of a general practitioner solely. Then you take the second one around nurses solely, and the third database around physiotherapists, midwives, whatsoever, solely. And these three databases together start reasoning and discussing with each other. And if one database contrasts or contradicts the proceeding of the discussion, it simply steps out of the discussion. Now, how can we imagine this? The first part I can show you here is I just hopped into this ChatGPT Health Medicine I showed you before. And then I told it, imagine three different experts are discussing the following case. All experts will write down step 1 of their thinking, then share it with the group. What happens here is I ask it to, okay, please grab 3 clearly defined knowledge bases I want you to work with. When you have them, write down the first steps of your thinking, what I will ask you, and share it with the other 2. Then all experts will go on to the next step, while expert 1 is a general physician, expert 2 is an advanced practice nurse, and expert 3 is a diabetologist. If any expert realizes they are wrong at any point, then they leave. So this is my primarily prompt to make the machine, the model, understand what I want. I want you to pretend to be 3 different experts. Now here is the case. As aforementioned, one of the things you can do with it is defining treatment plans. And this is something that we want to try now. Thinking we are general practitioner, we have a certain case, and we have relatives behind it in this case, and we have a nurse and a diabetologist, and we want to put together a treatment plan or something like a red thread line over 12 weeks, what the patient and the family and relatives can do to improve their health and a certain outcome. Now, the patient information, the case is quite simple. We have a woman, 45 years. She's 165 centimeters tall, 100 kilos. Her BMI is 36.6, which falls in B's class. Occupation, she's office worker. She's married, has 2 children. And now the major complaint, her name is Sarah Johnson, and her major complaint is she went to the family medicine clinic, concerns about her weight, elevated blood glucose level, and reports about feeling about increasingly fatigued. Also after meals, she noticed increased thirst, frequent urination over the past few months. To make it more applicable for the large language model, I added a history of present illnesses, which were the onset, duration. It's still since 6 months. She has all of these issues, and they worsened over the 3 months. The character of the illness and of the symptoms fatigue, we have the polydipsia, polyuria, and the weight gain. Associated symptoms can be occasional blurred vision, tingling sensations in the feet. There are no relieving factors, so we are already on a certain way to chronics. Then aggravating factors, symptoms are worsening after large meals and when it's sedentary. Still think and keep in mind, this is all what the knowledge base now knows. For the past medical history, she was diagnosed hypertension 5 years ago, hyperlipidemia 3 years ago, gestational diabetes, both in pregnancies, resolved postpartum. And for the family history, of course, as she's at a family medicine clinic, family practitioner clinic. Her mother already suffered type 2 diabetes, hypertension, and obesity. Her father, coronary artery disease, and hyperlipidemia. And the siblings, one brother with a hypertension and obesity. So we already have a family thing going on here that impacts her health now. She's not smoking, occasional drinks, but has high intake of processed food and sugary beverages, low intake of fruits and vegetables, and a very sedentary lifestyle with minimal physical activity, which somehow makes sense as a work as an officer. As we have the standard medications of her. She has some lisinopril, some atorvastatin, over-the-counter, the occasional ibuprofen for headaches, and of course vital signs as we have taken an anamnesis, vital anamnesis, blood pressure 140/85. So all of this goes in now into my request. What can we do? You three experts sitting here, please give me suggestions as an interdisciplinary team. And funnily enough, sorry, Robin, this custom GPT calls itself Robin as well. So surprise, wonderful thing. It takes this information and starts with a question. So it reads it and asks me, would you like to proceed step by step as the three experts discuss their approaches, or do you have a specific aspect of Sarah Johnson's case in mind? So before it does anything, it asks me, how do you want to proceed? Well, as I have to be quick, because let's say the situation is like, I have this meeting with the nurse and the diabetologist in 20 minutes. And I want something to take with me because I had so much on my head, the whole pre-noon phase. So I just conducted interdisciplinary discussion among the three experts on weight management, diabetes control, and lifestyle changes, so we can offer the patient something. Now, this is exactly what it does. The step one, initial assessment, the general physician puts in his point of view, the advanced practice nurse puts in her view, and the diabetologist, puts in his view as well. Which means step two, lifestyle modifications. The model is doing now, it grabs the information from each sole database on general practice, on the knowledge on advanced practice nursing, and the knowledge of diabetologists, and starts to compare. So for instance, step three, monitoring and follow-up. The general physician says, Sarah should learn self-monitoring of blood glucose to understand how her diet and exercise affects her levels. Regular follow-ups will help adjust her treatment plan based on her progress. That's the perspective of the physician. The advanced practice nurse says, yes, we should monitor her blood pressure as well, and the lipid levels, ensuring her hypertension and hyperlipidemia remain controlled, and coordination with her primary care team is essential. That's the nurse perspective. And the diabetologist says, okay, the regular A1C testing is of course clear. Comprehensive diabetes care is the next, including eye and food exams are necessary. We must educate Sarah about potential complications like retinopathy, neuropathy, and importance of early detection and management. Now, all of this summed up results in a patient education and support plan. And as this was all written text, I simply asked it, okay, show me the whole thing, show me the whole main points of each expert in a table. This not only makes it more visual and more understandable, but we can also draw certain conclusions between certain phases of the initial assessment, lifestyle modification, monitoring, following patient education, and conclusion. So as all of these treatments just work, and treatment plans just work, if they start properly and have a defined deadline and not run over a month, we say, now go back to the initial case details and develop a treatment plan for 12 weeks and present this 12-week plan as well in a table. So as you can see on the left side, the weeks are defined 1, 2, 3, 4 to 12. Which actions and goals are in these weeks? The initial assessment, we start with the metformin 500 milligram twice. We refer to a nutritionist for personalized diet, training and planning, educate on self-monitoring. And who is responsible for this? The general physician and the advanced practice nurse. The same goes for the lifestyle modification. Here, already the general practitioner is out. The nutritionist and advanced practice nurse take over. After 6 weeks, which is the middle, we need a checkup, the monitoring and adjustment phase, where Sarah is back to see the general physician and the nurse. For instance, adjustment, metformin dosage if needed, to increase it or whatever, depends what the results are. Then she is back out for week 7, 8, enhanced support and education, intensify lifestyle changes, and finally evaluation and long-term planning. Now here again, the general practitioner is out, and nutritionists and the practice nurse take over again, and the diabetologist, sorry. Yes, and in the end, all the three come together as interdisciplinary team in primary medicine and discuss the whole thing with Sarah. Now, of course, we know that such plans are just as good as the family and the relatives support the patient. So I thought, okay, now outline a supporting care plan for the relatives in a table that complement the 12 weeks plan. Now, what exactly can they do? What can we put in Sarah's hands that she discusses with the relatives to get the whole thing running? Here as well, it gives us a good idea in the short plan about what to tell the relatives and the family. So, for instance, educate family on Sarah's diagnosis and treatment plan. Provide information on the importance of supportive home environment. Encourage family participation in healthy meal planning and preparation. So this is something with an interdisciplinary setting with a kickoff meeting of 15 to 20 minutes, or let's take it 30 minutes. Everyone comes together in a room. This treatment plan goes on the table and can be fine-trimmed and fine-adjusted together. In the end, I asked it, lovely, now it is always a problem for someone to follow strict a table. It becomes boring, it's just a table, you just tick it off. But give me a narrative step-by-step plan, how the relatives can support Sarah. Make it compelling and engaging. Now this is something that can go into a brochure, for instance, or in a certain folder we can give Sarah and the relatives. This reads like the following. Week 1 to 2, understanding and engagement. Learn together. Sit down as a family and learn about Sarah's diagnosis. Understand what type 2 diabetes is and how it affects her. Attend an educational session with her healthcare provider. Set goals. For instance, include healthy eating, being more active, reduce stress. For week 3, 4, as a family, make lifestyle changes, not only healthy eating, but family fitness. Introduce family walks after dinner, bike rides on weekends. Aim at least 30 minutes of activity 3 times a week. Celebrate milestones, like walking a certain number of steps together. And of course, the monitoring and supporting part, deepening the commitment. This is the midpoint review where everyone sees, okay, Sarah progressed in her endeavors to get rid of diabetes, weight whatsoever. And how can we help? How can we support? This can be after 6 weeks, another 30 minutes meeting or 15 minutes meeting just for the checkup. And then off they go as a family, as a team again. And in the end, celebrate together, celebrate the end of the 12-week program as a family. you did it, or where can you improve? And overall, stay positive, keep a positive attitude, stay connected. If there are questions coming up, call us. And of course, make it fun. Turn challenges into fun activities. So, and now for the final part, the ethical part, which is very, very vital in developing such plans with large language models. I ask it, list the ethical concerns that we as a healthcare team and the family have to keep in mind. And this is exactly what it comes up with. On the one hand, the ethical concerns for the healthcare team, we know it, of course, but sometimes in the pressure and the heat of the day and our duties, we might forget one or the other thing. But here it comes up with patient autonomy, confidentiality, informed consent, non-maleficence, beneficence, justice, cultural sensitivity, empowerment. This is something we have to keep in mind. And the ethical concerns for the family. Now, it is heavy. It absolutely, it is tough. It is insane to change lifestyle within 12 weeks when you have a diagnosis over years. But for Sarah, in her case, the family wants to assist and help, but we have to make them understand not overdoing it. So respect the autonomy of supports of Sarah's decisions, respect her wishes, privacy, support without pressure, sensitivity to emotional impact, balanced support and independence. Now, these are all things to think about. Fair distribution and responsibility among the family members. So these are all things that easily done, and I think I used for this 10 minutes for the prompting. But when you imagine that many of the treatment plans start working and start delivering results, when they somehow become formal, official, in some kind of a contract between the interdisciplinary team and the family and the patient, this is something you can easily print out. You just copy paste it in a Word document and give it in the hands of the family. Go it through point by point. Everyone has to sign it, and then it becomes official. Now we are starting this journey. Now we are starting this treatment journey of your mother, of you, Sarah, as an interdisciplinary team. I think the time saved for general practitioners just by putting in, let's say, a report you already have, putting all the other disciplines and other experts you need in there, gives you, if not a printable and usable document, if not that, then at least a good idea where you can move and fine trim. And at least when it is copied to Word, you can delete and fine trim on the go as you wish. So this is an example, I think, where the tree of thought model and prompting with ChatGPT makes absolute sense for general practitioners to use. And now back to the presentation. You can see the presentation again?
Not yet. Yep, there it is.
Here it is? Okay, thank you. So now we have to think about a couple of things. All of what I was speaking now, telling you now, was very clear and very obvious, because we just got a treatment plan out of what we already knew. We always have to keep in mind that the answers only can be just as good as the primary data that goes in the basic knowledge base. These experts are providing their decisions, reasonings, ideas. Now, commonly it is said that large language models, or language models as such, have updated information readily obtained for patients and healthcare providers' use. Now, is this true? Is this true? And which kind of information is in there? For instance, we did an experiment with exactly this tree of thought method on the Medical University of Vienna with students, and we found out, this was interesting, that in step 2, step 3 of the reasoning and the discussion, suddenly the nurse comes up with the idea that she will order an MRT or order an X-ray. Now, this is something that in the US for an advanced practice nurse base is commonly okay. But in Europe, we have an issue with that because a nurse can't go and order MRTs as she wishes. So we have to understand that the main mechanics of the large language model ChatGPT are US grounded. We have a similar system here in Europe, which is called Mistral. Mistral already has the European guidelines and fundaments in it. So it would be more logical to use Mistral, but it isn't on it's not in the heads of the people until now. And always keep an eye on how updated is the information. The reduced risk for selection bias. AI is not influenced by personal beliefs or opinions. Yes, this is true, but based on which knowledge base? Because when the knowledge base already is corrupted by biases, then of course it just can't interpret what goes in. Reducing time, costs, and efforts. Databases searching, screening, selection, and extraction allow fast creation of evidence-based guidelines and policies. Yes, and again, but what is the primary database and the knowledge base? Now, customized GPTs allow, or as we have it with the system Claude, you can put in your own database and ask it, just use the data I just uploaded, just use this information and nothing else. Then you come up with pretty good results when it comes to evidence-based in the sense of, I know what went in. For the problematic part, risk for information bias, of course, AI is based on the data sets as mentioned. And the other thing boils down the inability to understand the context. The AI might not always have a full understanding of the context of the data. It pretends to give us profound and elaborate answers. But with the context window, we have to understand that it can only, like in this case, in the aforementioned case that we've seen, we just put in the case of Sarah. Yeah? We don't have any explicit other things like what is your health behavior outside? Is she a social being? How did it come to this kind of obesity? Is she happy with her work? Maybe she could change her work. This is not in it because we don't have the frame, we don't have the window, we don't have the clearly defined boundaries of the word limitation. And this makes it tricky because on a certain point we have to decide what goes in and what not. And this lowers and makes the window smaller and smaller for high quality answers. So it is said that, however, it is heard of that. What you see here is an evolutionary tree of large language models starting in 2018. So we are talking about 5 years, and within 5 years, it exploded. We have on the left side here these hyper-specialized bird machines and everything that goes within clinical, or let's call it specialized language models. Then we have the under different architectures and approaches, how to do it with the Google approach. And then, of course, an overall approach where everyone has a fit in and an eye in. I love the names, by the way. We go from chinchilla over the sparrow, Jurassic, which, to be honest, when we start with Jurassic here, how much can it explode further? So it is heard of that all these models, as far as they got. Undertraining of large language models is always a problem because we don't know the boundaries. How much is enough? Cost efficiency of smaller models is clear. The tinier, the smaller the model, the more efficient is it in producing it. But it results in high training and inference costs because still the training is not enough. We have to stay updated. Dated in the form of data bottlenecks. Data bottlenecks always show up and arise when do we start talking about different fields? Are we still in, let's say, are we still orthopedics? Are we still talking about other clinicians? cardiologists, general practice, family medicine. Where are the bottlenecks? Where are the interconnection problems? The data generation and the quality, of course, which leads to data pollution. By data pollution, it is meant that also the database picks up and takes input from Wikipedia or blogs or interesting websites which call themselves medical and evidence-based, but actually aren't. So then the database itself is polluted, and you don't know exactly, can I believe the outcome or not? Compute optimization challenges. Then, of course, speculative sampling and temperature scaling. What is meant by that? With this, it is meant that if you allow the model to fantasize, to do random stuff, to make their statistical approaches to find an answer as free as possible, it's like with us, when temperatures go up, and it's the same for large language models, randomness of answers come back. And if the temperature is low, like in our brains, then we become more focused and more deterministic. So it can help on the one side, for instance, come up with creative new ideas within interdisciplinary settings of treatment or whatsoever. When you put up the temperature, when you lower it, you become more focused. So this is another issue we have to think about. When and in which cases does it make sense to approach a healthcare or treatment plan with more randomness, and in which cases not? Now, therefore, in my opinion, right now, it needs a consolidated and unified framework to harness the untamed potential of large language models from primary care experts very, very soon. Right now, we are in a phase like, how can I put it? When the Lancet was invented, when the first tools for medicine was invented, I don't think that the first questions were ethical questions. It was more like, oh, wow, it's new. What can I cut with it? Not, is it appropriate to cut with this in this certain case? So right now, all the large language models, all these clinical language models, medical language models, are an exploding vast field for gamers, for trying, for experimenting. And I think we are all very clear that experimenting only in a very special sandbox environment is okay, but not when it goes live and using it for real treatment and real decision making with patients in primary care. So a framework could look like this: ethics of AI to guide us to an ethical usage of AI. In there should go transparency, data security, autonomy, intentionality, human bias, accountability, ethical standards, rights, automation and job replacement, accessibility, democracy. So many, many, many things that we have to keep in mind. And in my humble opinion, it would be appropriate for primary care medicine to come up with such a framework ourselves and not get it dictated from above, which, like the AI Act in Europe, is definitely a very nice thing and good thing for harnessing economic and problematic issues from overtakes from America, China, wheresoever. But for the field of primary care medicine, it would take now an approach to think about a framework, what goes in there, to present it to the producers and to the software manufacturers of these large language models. Which brings me to the final point. Can you help us with your expertise? On 17th of September in Ljubljana at 11 in the morning, which is kind of nice because we all come back from a walking, cycling, running tour, not specifically in this order. We have a nice workshop of 90 minutes where we have AI in action and the practical applications of large language models in primary care, where my team and I bring 4 or 5 medicine students with me from the Medical University of Vienna. So we can, they are the digital natives. They already think, what can we do good with it? I'm more of a digital native. I lost this of taming, and I'm still thinking, how can I use it after all? So that's why in this workshop we will think about large language models in diagnostics, large language models, personalized treatment plans like we've seen, predictive analytics, ethics, and we have a practical session. So bring your own device and let's have some case studies, real world applications, and just think about what is it good for and what might go absolutely horrible wrong if we use not. And then proceed with an understanding of what could go into a framework of ethical use in primary care medicine of large language models, gold standard. So I think I'm in time. That's it. And I'm open now for Q&A. Thank you.
Thank you very much, Florian. That was a very, very interesting presentation. I think we just have one question so far in the chat. I don't know if Jel Koper, if you want me to read it through, or if you just want to have a quick
in the chat.
Chat. Yeah. So basically, said I'm researching the use and impact of digital applications in general practice. Later in the year, they're going to be sending out a survey to the general practices in the Netherlands. One of the questions will focus on the use of AI in general practice, as it may not always be clear for general practitioners or GP staff which applications to use. They think it is important to make the question not too difficult and present only a couple of well-known popular applications, AI applications such as digital triage tools, speak-to-text registration, chatbots such as GPT, and supporting AI tools for better diagnostics. Do you have any suggestions which AI application categories that they should ask them?
Yes, a lot. I have a lot of ideas. And Jelle, thanks for this really, really profound question, because that's exactly the issue. We're talking about so much stuff in the meanwhile, and no one is not really clear what we should talk about. Why is that? Because on a weekly, if not daily basis, we have a mixture of highly paid marketing departments of companies that show us the best new next thing. And we have very enthusiastic amateurs who deliver us on YouTube and wheresoever ideas how to use it. So it's right now an absurd intermix of there is the new product, there are some that play around with it, and some that give ideas how to use it. And in the end, we don't really know what is true and what not, because everyone wants to gain its money with it. I would suggest, if Jelle wants me to, I drop him a line, a mail, to make our heads around what would be the most useful. Answering this right now out of the belly is highly unprofessional, because, yeah, it won't help it. I fear it would make things worse. This okay?
That's very much okay, Florian. And Jelle will be in, this is Diederik, Jelle will be in Ljubljana, so you can discuss this at the spot. So happy to have, to hear you, to make some advertisement for the Ljubljana conference. Florian, I have a question, a more philosophical question. What in the end is the added value? Is it gaining time, being faster, more efficient? But then the philosophical question, do we really need to be faster? Is it already not fast enough?
Thanks so much for this one, because I was lately discussing this with a friend of mine who is a complete different field, who is a biologist, and I meet him always at the Danube Riverside when he's walking through the meadows, picking his probes, and then going home and say, yeah, I have to wait 2-3 weeks now until I get my results. And I was thinking, what exactly does it better now? Is it really like, and in which field? I think it has, like with video consultation, there are certain niches where it can be really, really helpful. If it is supported good enough, if it is serviced good enough, if everyone is trained on it and can use it, and then good it is. But it is not the overall, I don't know, deus ex machina that comes now and helps us solve all our problems. I'm absolutely on your side. It will It will not, I think in some way it will harness us and will set the pace for us. And this is unacceptable. And even the more that a potential framework should be shown as soon as possible, where it is an absolute no-go and where there should be a stop button and an emergency button on the table or under the table of the physician when things get awry. I already heard of a product, of a software solution that can listen to the patient-physician communication, the whole speech. And while they are talking, it derives certain diagnosis ideas, codes them, and presents them to the physician. Now, this sounds awesome, unbelievable. But what, in the very moment, the diagnosis is in the wrong throat of the patient, and we have a dissolving, poor existence there, which has absolutely no idea what the diagnosis means and breaks down physically, psychology, and we need time then. We don't need a machine that listens to all of this. We need the chance to stop it and say, oh, okay, now we have a situation here where we at least need 30 minutes and maybe a mediator or someone, because here is something going on we don't know. Yes, I'm absolutely on his side. It can be a helper, like, I don't know, a blood pressure device. Nothing more and less. I don't want it to be more, to be honest. But are you in Ljubljana then?
I will be there for sure. Yeah. I'm trying to organize it, so that will be fine.
That's exactly the question we should discuss over a glass of wine.
No, sure. But what was the intriguing part that you, in your example, you suggested that it could help interprofessional collaboration, if I understood you well. So that's indeed sometimes, if it could boost this way of working, it might help. But still, I think crucial for this is bringing those different professions together, and that can be also in real life and doesn't have to be on a digital tool.
Yeah, I really was thinking a long time about which example to present to you all. I think that, and then I was just thinking about what is the, as you say, speed and pace within a primary care center on a Friday afternoon, and then this and that and so forth. This is something that maybe can send out before a meeting as a discussion base, and then you walk through, I don't know, 8, 10, 20 diabetes patients with a similar background and similar development, because they just came in, and it makes it maybe a bit more quicker to put out information to the patient that you can give to them, personalized, customized, so they can take it at home with the families and sit and think about the whole thing. Because as you know, most of the time patients go home, tell it at home what happened, and then everyone is like, yeah, so what, it's not me. But the relatives and family are a high potential actor in a treatment plan, mostly overseen and undernourished. But just giving them something so that they're happy, something to read. And if not reading, I mean, yeah, you can discuss it shortly. When I say shortly, yeah, 10, 15 minutes together in the team. Then they see, okay, there is someone who gives me something, and there are at least 3 people I can talk to. It's more like building safety, trust whatsoever in going the first step. After all, and when the whole language model is trained or connected to the database of your primary care center or private practice, it already knows your demographics, your geographic surroundings. You can add other supporters and other helping system that are around within 30 minutes, for instance, and included as well. So for just pressing or just putting out information in a quick way, which can be edited fast, I think it's a good thing. But as you said, then there are the special cases where you can't use it. But we all of this we have to find it out. We are in a position where we can't say. Robin, can you take a snapshot of the chat because I've seen the LinkedIn
Sure.
links. I would follow up with this and contact everyone personally.
Sure.
Thank you.
Yeah, and if there are no other questions, or if you don't want to come forward with your questions, you can, of course, send them through email to our info euprimarycare.org address, and then we post them later on. But if there are no other questions, Robin, I think we should wrap up in the sense that it is already 1:30. And you were quite impressive, I think, Florian. So people are a bit shy and overwhelmed by this storm about artificial intelligence. But that's fine. We're looking forward to it in Ljubljana, definitely.
Okay, that's very kind. Thank you.
Oh, there is one more question. Sven, go ahead.
Phone. Yes, thank you. I have a question. We do the body and the brain scans of the aviation pilots. Maybe you don't know that, but all the aviation pilots, they have to reactivate their flying license by undergoing a full body and brain scan every month, semester, depending on the type of airplane that they fly and the duration of the flight. So we have a huge database. Imagine following the career of a pilot over 30 years, starting at the age of 25, and then every month or 6 months doing a full body and brain scan of healthy people. So we have a huge database on that, and that would be, we are wondering how we can make that database available for research and the learning models. And another question that we have is, yeah, you have the health union priority on everything that is the patient health record and the patient data vaults. So all the patient data, they actually belong to the patient. So yeah, right now this database is belongs to our company, but we are wondering. Yeah, we know of course the names of all the pilots, and actually this data belongs to them. So I understand that there are that we are going to make, that we have to somehow give back all this data to them. That it is being uploaded in their electronic health record and their patient data vault, and that they then have to check mark if they want to make their data back available for example, training artificial intelligence models. Is that right? Have you had some of these cases already before, or do you know more about that? Because I haven't had time to read up on all that. Thank you.
I heard, I'm not really dived into it, but I heard of something similar for the, not for the pilots, but for the, how they are called, who sit at the, who have to check the flights, where they are going, and organize the people in the tower. What's the word for them?
Yeah, there's a flight tower supervising teams.
Doesn't matter. Go ahead.
Yeah, it's quite simple insofar as you already have the data set. When you see them on a regular base monthly, it's just a question, a matter of two things. Anonymizing the data with a code book, which can be done with a customized GPT already, or a customized small large language model. So it already codes it and anonymizes it. And then you just need a consent form that allows to use the anonymized data for this. I have to check. I hope. No, I know which case it was. I can check this and send it over to you. It can be done rather easily, and if you pack it in a narrative like it's good for everyone, because then we can have risk development. We can see where certain things are going in certain ages, for certain planes and so forth. And as I understand, it's mostly about reporting so that they get their monthly report. There, I think it could be a highly, highly interesting solution, yes.
So, and if I understand well, this whole electronic health database record and so forth directive that will kickstart from the end of from this year, right? Then there is a timer, there is a clock that starts, if I understand well, and then companies have time to.
To be honest, I would run a test for a month with anonymized data in a certain field on a certain plane or a certain age group or female, and then just run this test for one time, and then you see the outcomes. This is rather easily done.
Robin, can you wrap up, I think, because otherwise we run too late.
Perfect. Thanks very much, everyone, for joining us, and thank you once again, Florian. And just a reminder that this presentation will be uploaded to our YouTube channel. Diederik has put the link in the chat. But yeah, I just need to edit it and clean it up, and then it will be uploaded by tomorrow, latest. Thank you very much, everyone.
Thank you. Have a lovely afternoon.
Yeah, and see you all in Ljubljana. Thanks a lot.
Yes.
Bye-bye.
Yes. Bye.